I'm Patty, and I'm the chair of the Health Day Committee this year. Took over from Pat Butler, who started this 18 years ago. Yay! So I wanted to welcome you to your Health Day of 2024. It's great to be here, and to our audience online, thank you for joining. I'm going to go through some housekeeping tips for your comfort today. The emergency exits, there's 4 in the room. Take note of those. The restrooms, I know many of us have come here for the UMRA meetings. They're just outside the door and to the left. You got some packets today. In the packet is, on the yellow sheet is the agenda, and you have an extra piece of yellow paper to add more notes to. And you got a blue piece of paper, which is the survey for Health Day. So for those on site, please complete that at the end of the day, and we use that to make improvements or additional, gives us ideas for future topics. So the schedule for the day is, we have the first presentations will address, all of them, will address pain, cardiac, mobility, noise, and vision health topics. These were all chosen from last year's suggestions. There will be a Q&A session after each speaker. The speaker gets 50 minutes, and then there'll be a 10-minute Q&A session. And to stay on time, we've got a timer up here who will help the speakers and us through our Q&A time frame. Please save your questions to the end of the speaker's talk. And new this year, we want to try and get as many questions in as we can. We have a microphone that is set up in the middle of the room. So you can come up to the microphone, and one of the committee members will be there, and we'll hold the mic, hand you the mic, and you can ask your question. That way, instead of waiting for the mic to make it around the room, or for us to yell out questions, you know how it gets to be. Those who are at viewing from home or wherever online, you can ask your questions by sending an email to umra@umich.edu, and we will have someone monitoring that. If you have some mobility issues in the room and you would like the microphone to be brought to you, just raise your hand and one of the committee members will bring you the microphone. This morning we have 3 presentations: pain resilience, cardiac health and anticoagulation, and fall risks. There'll be snacks throughout the day. Please help yourself, get up, go over, and feel free to replenish your coffee, get another muffin. Lunch will be from 12 to 1:30. There's no need to leave the room. We're going to do it like we did last year, where you have these little meal tickets that you got with your packet. Place them on the table in front of you so the servers know what you ordered. This lunch break includes 15 minutes for you to return to your seats and us to give updates. So technically, at 1:15, we ask you to be back at your seat. I do have an obnoxious cowbell that maybe, if people aren't returning, I may have to go around and ring the cowbell. And after lunch, we'll have 2 presentations, one on noise and impacts on health, and ocular health as we age. Feel free to get up and move if you need to. Stand at the back of the room, pace at the back of the room. Sitting for a long time, I know, can make us stiff. All these presentations are going to be live streamed and will be recorded and uploaded to the University of Michigan Retirees Association YouTube channel. So you can go back and view them again. Those at home, if you have to get up and you planned on just half a day, you can view them at later or revisit them. They will also be made into podcasts. Any of the handouts we received today I believe there's one in the packet. It will be uploaded as well to the UMRA website. People will be taking photos throughout the day. So if for some reason you don't want your photo taken, just let us know so we won't do that, because these will be loaded up to the UMRA website in the newsletter. I would like to thank University of Michigan Human Resources for sponsoring a portion of this through a grant, and the help from many of the UMRA board members for today's success. Roger has been, oh my goodness, such a great help. This is the first time I've done this, keeping me on, okay, where's this, where's that? And at this moment, I'd like to introduce the committee members. So I would like you to stand up when I say your name. I'm Patty Beebe. We have Pat Butler, and many of us know Pat. Where are you at, Pat? Yay! Carolyn Brewer, there by the door. Wave your hand there. Mark Kempton is right there. And Mark doesn't get to make it to any of the UMRA Thursday meetings because he's working part-time, and it happens to be on a Thursday. Elaine Fellows, where are you at there? Woo. Beth Veneer, over there. Sandy Reggiani, she'll be the timekeeper for the speakers and us today. Stephanie Marinath, I hope I said that right. And Madeline Lotman. Oh, she's out helping register, check in people. I ask at this time you take a moment and turn your cell phones and alarms to vibrate and silence. And right now I'd like to introduce Mark Kempton. He was very helpful in getting our first speaker and working through all the logistics of this. Thank you. Everyone have a great day.
Good morning. I'm Mark Kempton. I'm one of the members of the Planning Committee for Health Day. I'm here to introduce Dr. Hassett. Just a quick heads up before we start. As noticed, there will be time for Q&A at the end of the presentation. But if time runs out, for those present here, Dr. Hassett has graciously agreed that she'll stay after the presentation and take additional questions outside in the lobby while we transition to the second presentation. So don't worry if you don't get to your questions here. If you want to, you can meet her outside in the lobby afterwards. So Dr. Hassett's presentation is titled Pain Resilience and More Rewarding Self-Management. Dr. Hassett is a licensed clinical psychologist who is an associate professor and director of pain and opioid research in the Department of Anesthesiology here at U of M. She is a principal investigator at the Chronic Pain and Fatigue Research Center, where she conducts interdisciplinary research related to exploring the role of positive emotions in people with pain, as well as developing novel interventions to promote resilience and better pain self-management. She is the author of an exciting new book titled Chronic Pain Reset, 30 Days of Activities, Skills, and Practices to Help You Thrive. It was written for patients and to support clinicians in their care. So join me in welcoming Dr. Hassett so we can start our day in her presentation.
Thank you, Mark, and the entire team, and thank you for being here. I'm delighted to spend a little bit of time this morning with you talking about something I think a lot about, and that's chronic pain. As a principal investigator at the Chronic Pain and Fatigue Research Center, I work amongst a really wonderful interdisciplinary group, and we really are one of the largest and perhaps most recognized pain research groups in the world. So it's just an honor to do that and an honor to be here before you. So, there you go. How is this? Is this better? Great. So if you do not have chronic pain, and I hope you do not, you most likely know somebody who does. This is an incredibly vast and significant healthcare problem. Before I get started, just quickly my disclosure. And today I'm going to cover a few topics. So we'll talk just briefly about what is the problem of chronic pain in the US. Then we'll touch a little bit on the neuroscience of pain because I think it tells us so much more about how we can do a better job of treating it. We'll talk about the concept of resilience as it pertains to pain, but as it pertains to life too. If you don't have chronic pain, I hope there's so much you get from this, nonetheless, because so many of these principles that help us treat chronic pain help us have richer and more rewarding lives. And then lastly, we'll talk about some of these interventions that can be done by our patients, by our clinicians, and by you. And then I'll touch briefly on some ongoing research that's related to this specific area. So we begin with the epidemic of chronic pain. It's huge. Chronic pain is defined as pain that lasts greater than 3 months. And we estimate that close to 20% of the US population of adults has chronic pain. That's about 51 million people. It disrupts people's lives, it disrupts ability to work, it's extremely costly to our healthcare system. And then having chronic pain is associated with many things that portend a poor life, including depression, the onset of dementias, higher suicide risk, and substance use and misuse. And then of these, about 17 million, 7% of people in the US have high impact chronic pain, which means that it is a great disruption to them, to their lives, as well as to our healthcare system. And in a recent study, they found that new instances, fresh instances of chronic pain occur more frequently than some of our most common diseases, including diabetes, depression, and hypertension. So it is indeed an incredible epidemic. So chronic pain often doesn't occur in a vacuum either. What we often see is a symptom complex that includes poor sleep, fatigue, cognitive difficulties, so difficulty with memory, depression, and anxiety. And these processes also make pain worse. So stress, poor sleep, poor mood. So you can see how it's cyclical. These co-occurrence of pain along can make the pain much worse. As such, because it is so complex, most of our treatments are interdisciplinary. We often start with medication, but almost more importantly are other types of interventions. Department of Anesthesiology, we do a lot of interventions. We can do blocks and we can do injections. But what we really see, the long-term more effectiveness are things like physical therapy and exercise. The behavioral therapies to teach people new ways to cope with their pain and how to deal with the disruptions in their life. And then the notion of self-management, pain self-management. As with any chronic illness, what a patient does to help their physician is probably one of the most important elements, the self-management of a condition like diabetes, heart disease, and chronic pain. I'm sorry, might be one behind. All right, so pain is a wily character. It's not just a sensory experience, it also has emotional components or an affective component and also a cognitive component. And that makes it so tricky to understand and to treat. As such, pain is processed by many areas of the brain, not just one area of the brain. And these areas are all interconnected. And many of these areas also process thoughts and emotions. And so all of these bits can be mixed up into the pain signal and make pain a little bit more difficult to understand. So with that, let me just touch on the neuroscience of chronic pain. I want to do this kind of in hopefully a fun way. So let's talk about what a weird thing pain is. Okay, so we begin with the notion when I show this to radiologists and I say, hey, which knee hurts? And they say, oh, that's easy. Why the knee that hurts, that's got to be the one on the left, the one on the right there, because you can see this bone on bone. That's got to be incredibly painful. But what we see in the data is that this is not necessarily a great predictor of pain. Many people have absolutely normal looking radiographs and have tremendous pain in their knees and the back of their arms. And other people will have really ugly looking radiographs like that and say, I don't have pain. And I'm one of those people. My knee radiographs are awful, and I have no pain in my knee. And then there's this fascinating case too. So this is a case of a 29-year-old construction worker that jumped into a pile of debris, and a nail went right through his boot. And as he's staring down at this, he is screaming in pain, and his coworkers bandy around him, rush him off to the ER. He's beside himself. They give him some opioids to try and quell the pain. They take the boot off, and the nail passed right between the toes. There was not a scratch. And so what was that? Did he make up the pain? No. The brain puts together context and leaps to conclusions in ways that are protective. And so pain can literally be conjured on its own. We know through our studies that maladaptive thoughts like pain catastrophizing and fear avoidance can actually make pain worse. We also know that more adaptive thoughts, like thinking about one's optimistic views of the world, or something that makes them happy that day, or a sense of pain self-efficacy, actually makes pain better. These are experimental studies where we apply pain to people, and when they're thinking these thoughts, and have a sense that these are indeed protective. We know attention and distraction is incredibly powerful. This is a study, the PHRASE study is one we conducted here at the University of Michigan, where we gave laboring women in the first stages of childbirth virtual reality goggles. So they were able to watch this beautiful ocean scene during one contraction. Then we took them away for the next contraction. Then we gave them back for the next. And so they're their own control. And what we found is that these women tolerated virtual reality very well. They didn't get nauseous. We were worried about that. But that when they had the goggles, they got about a 40% pain relief. At one point, they're like, give me the goggles. And then negative emotion is very powerful in making pain worse. Depression, anxiety, hate, anger all make pain worse. But joy, happiness, gratitude, love make pain feel better. And laughter is probably one of the best analgesics we have. When you have a huge belly laugh and you're like, you can't hardly catch your breath and your eyes water, you often are expressing all sorts of endogenous opioids, which are analgesic. They actually decrease pain. And then social isolation. We'll talk much more about this down the road, but social isolation is highly associated with worse pain. And social connection. This was another crazy study that I love that had people dancing in groups to Gangnam Style. I don't know if you remember that Korean pop song a few years back. And dancing together in groups actually made pain decrease, made them less sensitive to pain. So what we learned is that pain is incredibly weird. It tells us very important things about the possibility of how resilience-based interventions could be helpful. First, we learned that cognitions, emotions, and sensory experiences are all neural events, and they are processed by many of the same areas of the brain that process pain. Damage and tissue injury in the experience of pain, optional. Psychological, emotional, social, cognitive, attentional processes all intricately are associated with our experience of pain, and changes in brain networks thought to be the cause of chronic pain are not hardwired. They can change. Neuroplasticity makes our ability to intervene on chronic pain very, very possible. Okay, so let's talk a little bit about the concept of resilience. That which does not kill me makes me stronger. That's the core of resilience. For resilience to even be, there needs to be adversity. So when there's adversity in one's life, resilience refers to our ability to bounce back, our ability to respond to the negative aspect. Resilience is typically thought of as a trait, but it isn't. It really is a more dynamic capacity to adapt to things that are thrown into you in your environment, to more successfully respond to negative events. And what's really exciting to us as interventionalists is resilience is a malleable factor. We can improve resilience through simple little interventions, small tweaks. So when we think about one's capacity to have resilience, it isn't a you got it or you don't. So really resilience can be low in some individuals, it can be moderate in some individuals, or high, which is our goal. But there's another level of resilience. It's thriving. some people in the face of adversity actually do really well on the back end of it. They find meaning in what it is. They actually grow from a negative experience. And the data are great for resilience. I'm really encouraged by this. About 20 years ago when I started doing this, nobody studied resilience in pain. But since then, we've learned that resilience predicts even the presence of chronic pain. It predicts whether or not pain is widespread, which is usually worse than focal. It predicts analgesic use, disability, pain interference in one's life. One's quality of life is often predicated on the level of resilience one feels. Depression, anxiety, post-traumatic stress symptoms are all not negatively associated with resilience. And resilience refers to good psychological adaptation, meaning that people accept their pain, that they don't catastrophize their pain, that they have a good sense of self-efficacy, I can deal with my pain, and so on. So when we think about what resilience is as a concept, I kind of think of it as 4 properties. I think there's connection, which is a really important part. Our connection to the people that we love in our lives, our social integration, our sense of feeling supported. I think our thoughts are really critical. Are we effective copers? Are we optimistic? Does life kind of make sense to us? We feel competent and that we're able to influence our world. We have a sense of self-efficacy. Our life has some meaning or some purpose. And resilience also includes our emotions, positive emotions, having more positive emotions than negative. We all have negative emotions. That's perfect. But having more positive emotions is critical. And this tells us what our treatment targets are too. We want to increase connection, so promote social support. We want to help people enhance the way they think about things, to be more optimistic potentially. We want people to feel more competent, have a better sense of self-efficacy and purpose in life. And we want to help people increase their levels of positive emotions. So at this point, let's do a pop quiz. Pop quiz. Okay, here we go. So this is a fascinating study conducted by Julia Holt-Lundstedt, and she went digging through all the medical literature, and she found all the most protective things that decrease your likelihood of mortality. Okay, and she said, hey, good evidence for clean air, it makes a difference. And you know what, you take your hypertension medication if you have hypertension, also really protective. If you have a lean body mass, if you exercise, all good. Flu vaccine, really good, get your flu vaccine. Less alcohol if you drink a lot, that's very protective for mortality. And less smoking, as we all would probably think, yeah, right, less smoking, very good for mortality. But there is one factor that they found that surprised the bejeebers out of them that is more powerful than even smoking. Does anybody have a guess? I heard social integration, social support. So powerful. Our relationships are incredibly important to our health. Alrighty, so let's talk a little bit about promoting social support. So our social relationships are really critical to both our mental and our physical health. They affect us through behavioral, psychosocial, and physiological pathways. The people who we keep in our world are who we emulate. If we eat it, if we work with a bunch of, or we hang out with a bunch of people who eat healthy, we tend to eat healthier. If we hang out with exercisers, we tend to exercise. So it has a great influence. There are many benefits for strong social integration, but on the flip side, negative relationships, abusive relationships, have negative health effects. So that's important too. And what we know, whether they're good relationships or bad relationships, there is a cumulative effect on our health. The more we're exposed to either these good relationships, the better our health. The more to the bad, the worse our health. And this is a study that we conducted here using the University of Michigan's Health and Retirement Study. I worked on this with Victoria Powell. She's a palliative care physician in oncology. And we looked at individuals who have chronic pain. We looked at 5,974 individuals from this study, and we looked at them at 2 different time points. And what we were interested in actually were people who had scores on loneliness. And what we did is we looked at those scores pre and down the road and looked at the ability of loneliness to predict the onset of things we don't want to see, such as pain and fatigue and depression. And yes, loneliness predicted all 3 of those. And loneliness also predicted all 3 of those occurring together. So people who had pain were fatigued and also lonely and depressed. So one fun activity that we do, I'm not going to have you do this here because it's very disruptive, but I promise, please do it during the next break. Scroll through your texts and find somebody you haven't texted in a long time and just send them a quick note. Just send them, hey, just thinking about you, hope you're doing great. Do this every day for the next week and just dig out people you haven't talked to in a while and do that. It's a simple, easy thing, and I think you'll be delighted by what you find, but it's an easy, low-cost way just to reach out to folks. Thoughts that enhance our resilience, and I mentioned optimism. Optimism is so important, and this is a study that we conducted with the individuals at University of Pennsylvania and the Research Facilitation Laboratory, and what we looked at is what can we understand about pre-deployment factors and how it impacts post-deployment pain. Chronic pain is a huge problem for the military across the board. And in this, in these Army soldiers, we were curious how optimism might impact new chronic pain. So we looked at 20,000 U.S. Army soldiers, followed them at baseline and over a series of deployments, and discovered that 37% of them developed new chronic pain post-deployment. And that's kind of what they, typically see. That's a lot of soldiers. Almost 40% have new chronic pain. And what we found is when we did an analysis comparing the most optimistic soldiers with the least optimistic soldiers, we found that the most optimistic soldiers were 35% less likely to develop chronic pain. So it's a really powerful predictor. What really knocked our socks off is this was still true after we controlled for deployment factors like multiple deployments and for combat exposures, like were you injured yourself? Did you see somebody die? On and on, these awful things that tend to make things worse. Optimism still was just as protective. And studies of optimism show that 70% of 69 studies that were looked at in a meta-analysis said, yes, optimism is shown to be protective. And what's even more so is that the better the study was of optimism in chronic pain, the more likely they were to detect a big effect. So the highest quality studies said, hey, 92% of these studies found in favor of optimism being protective for chronic pain. So we think it's very important, and we try and dwell here. And then there's also competence, self-efficacy, or having good purpose in life. So self-efficacy refers to the belief that one has a capacity to exert control over one's behavior, a situation, motivation, and social environment and health. And in a meta-analysis looking at almost over 15,000 individuals with chronic pain, they found that self-efficacy had a very protective effect for impairment, functional impairment, psychological distress, as well as the severity of pain. So again, this sense that I've got some agency in my life is very protective. And also purpose in life. I do whole talks on purpose in life, and hopefully someday you'll have Vic Strecker come and talk to you about purpose in life, another colleague here. But purpose in life really consists of your reason for getting up in the morning. What's meaningful to you? If you have a strong sense of purpose, it guides your life decisions, it influences your behavior, it shapes your goals, it offers you a sense of direction, it creates meaning, and it sure does buffer when bad things happen, because if you have a sense of purpose, you just roll with the punches easier because you know where you're going. And as such, the data are so good for the power of purpose in life in our health outcomes. People who have a high sense of purpose are less anxious and depressed, they age healthier, they sleep better, they eat better, they have greater willpower for making changes in their lives, they're at decreased risk for heart attack, Alzheimer's and other dementias, and just have better immune functioning. And what we are also passionate about is they tend to have less chronic pain. And these are the data. I didn't have room to put them on my slide. And then increasing positive emotions. So I have a whole separate section for this because I spend a lot of time thinking about positive emotions. I think this is kind of our silver bullet. So before we talk about positive emotions, let's talk about negative emotions, because oh boy, have we done a wonderful job studying all there is to know about negative emotions in health. We know about depression and anxiety and anger. We've studied these well, and in pain it is important because they are important. Negative emotions are associated with all bad pain outcomes. So if somebody is anxious and depressed, they're more likely to have high levels of pain. They're more likely to use more medication. They're more likely even to be discharged later from the hospital after surgery. So just about all pain outcomes that we're interested in are made worse by things like depression and anxiety. But that's not all we are, right? We are so much more emotionally diverse than just depression, anxiety, and hate and fear. We are full of positive emotions too. We express love and happiness and empathy and trust and passion and gratitude, and these are kind of cognitive emotional constructs, but they all emit different types of chemistry in our bodies when we feel them. When you feel love, there's a chemical mode, often oxytocin. When you feel joy, other chemicals are released, and these have powerful health effects. I'm looking at only pain here, but this is across the board, from everything from hypertension to heart disease. But here in pain, positive emotions are associated with all the good outcomes we want. Less pain, less analgesic use, earlier discharge from hospital, less sensitivity to pain, and so on. So these are very powerful and may even be more powerful than negative emotions according to our data. But there is a rub. So I'm showing you this slide because it shows data from the positive and negative affect scale. So positive and negative emotions are measured in two separate columns, right? So when people have high levels of negative affect, that's bad. We don't want them. We want them to have high levels of positive affect. So when we look at healthy individuals, you see 18 for negative emotions and 35 for high. That's good. We want to see kind of this 2-to-1 ratio, right? You got some negative emotions, but you got twice as many positive emotions. This kind of holds true for osteoarthritis, which is a chronic pain condition, but somehow they seem to be quite resilient. Lupus, too, kind of holds true. But in some of our other more widespread pain conditions or more long-term chronic pain conditions, like fibromyalgia, chronic low back pain, and pelvic pain, we see a slight elevation in negative emotions, but what we see is an incredible decrease in positive emotions. That's more striking. So what is going on with these lack of positive emotions? And so I've spent a lot of time thinking about what this could be. It's not just me, many of us. And part of it is that when people have chronic pain or even any chronic condition, they tend to give up the things in life they love the most. So valued life activities can be set aside in favor of doing the things you have to do. The housework, taking care of the kids, running the errands, work, etc. And all the things that we really enjoy doing, we often set aside. As such, the meaning in life gets lost, joy in life gets lost. Our relationships often tend to get lost. And in this process, we see that individuals with chronic pain and many conditions like depression, even post-traumatic stress disorder, they start being unable to find joy at all. And neuroscience tells us that this is often happening at the level of the brain. The part of the brain that processes positive events, the reward processing part of our brain, often changes. It adapts to the experience of pain all the time in a way that makes rewards not even detected. So something happens in your life and it's like, right? The brain is going, oh, that's awesome. And as such, then these people don't even go forward and even seek new experiences. The good news, though, is this change in processing of joy and happiness and positive things is reversible. In a lovely study conducted by Maria Kreitzes-Lacombe, she and her team showed that doing simple positive activity interventions like gratitude and savoring actually changed the function of the brain in individuals with depression and anxiety. Doing these simple happiness-promoting activities changed how the brain was processing reward over time, and again, they started getting back that happiness. This is a huge problem that we see in substance use disorder patients, where this part of the brain changes in response to the substance they're using, and we need to work at how do we get the joy back so that we can keep people straight and narrow. Okay, so I teased positive activity interventions. Let's talk about what some of these are, because you can do these yourselves. Okay, so positive activity interventions Include things like gratitude journaling, keeping a gratitude diary, conducting acts of kindness, savoring happy experiences or pleasant things, doing pleasant activities, making these part of your life, reflecting daily, thinking about what went well that day, having a sense of purpose in life, engaging in positive service, and embracing your strengths. Okay, so we'll talk about each of these. All right. Oh, but let me hit you with some science first. This is a lovely meta-analysis, a study of many studies that shows that people with chronic pain who do these little positive activity interventions actually have less pain intensity, fewer depressive symptoms, lower levels of negative thoughts like pain catastrophizing, fewer negative emotions, more positive emotions, and many of these effects last 3 months after doing these silly little things. Okay, so let's talk about what these are. These are things that we do with our patients. So the first one, and actually I teach undergrads too. I haven't since before the pandemic, but I teach freshmen. I do a seminar and I teach them these things too. And they come back to me years later and say, I'm still doing a gratitude diary. And it's made such a difference. So a gratitude diary is kind of whatever you say you want it to be, but the way I like to do it is you have a little diary, and I often say buy one you really like. Buy something fancy, put it by the side of your bed, and at the end of each day, write down 3 things for which you're grateful, okay? The trick, though, is if you try to write 3 different things down each day. So I'll tell you, you'll do easy the first 2 to 3 weeks. Then it starts getting hard. And you spend the day kind of looking, oh, that flower, that's a great flower. I'm grateful for that flower. And I got to remember that. This teaches you to encode these positive things in a way that it starts to stack up. Okay, starts to stack up in your brain, what you think about and what you seek. So gratitude journaling, very good evidence for this. Alrighty, one of my very favorite, random acts of kindness. You've seen those bumper stickers, conduct random acts of kindness and senseless beauty, right? These are beautiful little things that you can do just out of the blue. It doesn't have to cost a lot. It's just letting somebody in traffic. It's being aware. It's holding a door open. It's giving a kid a balloon. I mean, these little teeny things that you can do make a big difference. Doing them intentionally is the power. So in studies that have conducted looking at random acts of kindness, probably the best formula is to do 5 acts all in one day. So take a few days and plan them, because that seems to be part of what works well too. So think about what these 5 acts are going to be, plan them, do them for some strangers, do them for some family members. For people with chronic pain, we say do one of these for yourself, because often people with chronic pain don't take very good care of themselves and aren't very kind to themselves. So do one for yourself, and then have kindness day and just do these kind acts. And what's fascinating is how people react to you. Some people are shocked. If you ever bought somebody a cup of coffee at Starbucks out of the blue, they'll first look shocked and then kind of horrified and then so grateful. So doing kind things has very, very strong health benefits. And these are a few of them. Forward this. So data have shown that just doing these little random act of kindness, positive activity interventions have resulted in decreased levels of health-related stress, less depression in patients who have diabetes, lower levels of pain, which we care about, lower levels of cortisol, decreased blood pressure, less anxiety and depression. And we'll talk about this in a moment, but if you include positive service, volunteering as part of your acts of kindness, the health effects are way higher. Alrighty. Another of my very, very favorite interventions, savoring. Oh my gosh. We may not do this as much as we did as children, which is natural. It's like, oh my God, this is so good. And being in the moment and loving what something like the first taste of chocolate is like. Savoring means that you spend a moment realizing that something good is taking place. Something great is occurring at this moment. And you take the moment to think, this is a great moment. What am I feeling? What am I smelling? What am I tasting? Who's around me? Remember this moment. Remember this moment. We need to do this because we're very good at encoding negative things, anything awful that happens to us, a near accident, something that we really injured ourselves. If something awful has happened to a friend or family member, you encode that and remember that in memory forever. Positive emotions, you have to work a little harder to encode. So that's what savoring is about, is being mindful in the moment and really encoding that. So engage all your senses, be present, spend about 2 to 3 minutes, in reveling in this moment. If it's enjoying a cup of coffee, if it's a moment with a good friend, if it's petting your dog, whatever it is, just be there and enjoy it and savor it for a moment. Pleasant activity scheduling. When we do a lot of hard things in our life, especially when people who have chronic pain or other illnesses, all the fun stuff gets set aside. We talked about, putting aside our valued life activities. Pleasant activity scheduling just says, hey, put it on your calendar. I want you to put 2 things on your calendar this week, an hour, 2 hours, whatever you do, and treat them like you would a doctor's appointment. This is a prescription that we make for people with chronic pain and for people with depression. And the data for depression are so impressive. In a meta-analysis looking at positive activity scheduling in depressed people, they saw an effect size of 0.87, which means, oh my gosh, it is such a powerful intervention. We almost have no other intervention that is that powerful for depression. And what that is just getting people moving, engaged again. When people are depressed, they withdraw. And it's so important to get people moving. And this is true, too, for people with chronic pain. So we ask them to do pleasant activity scheduling, whatever it is. Schedule a massage, have coffee with a friend, just get out and do it. And this is one of my favorite. This is the positive piggy bank. What this is a intervention that we had to create out of need. I was approached by a lovely oncologist here, Lynn Henry, who works with women with breast cancer, and she said, hey, it would be great to offer people something before we do surgery. This is such a hard time in people's lives before they undergo surgery. They've just gotten this new diagnosis. But we don't have any resources. We can't throw a psychologist at this or anything. What can we do? And so I thought about it. I thought, okay, positive daily reflection. First of all, no therapist, so we need a way to remind people. So we said, let's get a piggy bank. So let's get piggy banks, because then you can put this on the kitchen table or someplace where it'll be seen. And then we'll give them little slips of paper, and then we'll give them a little card. That's all we need, okay? And so put them in a bag and give this to them. So that seemed like a good thing. On the little card that they get, it says, every evening, think about the people, things, or events for which you are grateful. For the cancer patients, we said for happy, things that make you happy. You may make a list if you like, pick one of these and spend a moment savoring it. What about it made it so special to you? Now write down this moment on a currency slip, a little piece of paper. Use enough detail that you could immediately recall what happened later. Next, add a date. Fold it up, put your little memory slip, your little happy or grateful memory slip in the piggy bank, and fine. And then the next day, do the same thing. Do this over 30 days. When we did the breast cancer study, we had to do it over 2 weeks leading up to surgery, right? So whatever time frame works for you. I've had people do this for a year. So then what we say is at the end of the 30-day period, 2-week period, 1-year period, you'll close your account. This means that you withdraw all the currency from your piggy bank and read each and every one of the deposited happy memories. As you read them, try to recall the details of what happened. What about that event was so special to you? And enjoy. Remember what I said, we don't encode happy things as well as we do negative, and when we get these slips in front of us, it's like, oh, I totally forgot about that. What a wonderful event. So it's really a wonderful way to recall. This is a fun thing to do with family members. It's a fun thing to do at the dinner table. I've had people do every iteration imaginable of this positive piggy bank. And then, as I alluded to before, the power of positive service. I imagine quite a few of you volunteer, and if you don't it's good for your health. In a really excellent study looking at another meta-analysis, looking at study of studies, looking at the benefits of volunteering, they found that social benefits, there are mental benefits and physical health benefits, and these are pretty profound just for volunteering. Other studies have shown that if you're volunteering because it's something you're really interested in, and so you're a docent, that's just as good as working at the soup kitchen. It doesn't kind of matter what the motivation is, it just matters that you do it and it feels gratifying to you. So volunteering is a very, very positive, very important positive intervention. And then lastly, this is something I'd love for you all to do if you've not done this already. Do you know what your character strengths are? Has anybody done this before? Sought their character strengths? Character strengths are our superpowers. These are what are unique about us. We kind of know what they are, and you might be able to name them because we often have a sense, oh, I'm good at that, right? So character strengths are actually kind of the DSM-4 for health and joy. It was developed by Chris Peterson and Nanswick Park here at the University of Michigan. Chris was, and Martin Seligman at University of Pennsylvania. And what they have done is they spent about, I think they spent a year looking at all cultures around the world to find out what people value. And what they identified is there's kind of 7 virtues that most cultures agree on: wisdom, courage, humanity, justice, temperance, and transcendence. And with each of these, within these virtues, there are a series of strengths. So within wisdom, we have creativity, curiosity, judgment, love of learning, and perspective, right? And so on through courage, bravery, perseverance, honesty, and zest, right? So each of these has a set of characteristics. If you would like to, you can go to the VIA website. It's a nonprofit organization that just collects these data just to understand the world. They've had millions of people complete this form. It takes probably about 20 minutes, and you get a free PDF at the end of all your character strengths and what it means. And so the quiz is actually kind of fun, and it makes you kind of think, what are my strengths? And I think what I have my students do this too, and they always, the first couple are like, yes, yes, and then there's always a weird one in there. Oh, that's so interesting. I never thought that this would be one of my strengths, be it forgiveness or grace or whatever it might be. And it helps us think about ourselves in a different way. And what we do with character strengths as an intervention, once we know what our signature strengths are, the ones that are most pertinent to us, is we try to think about new ways to use them. So if your strength is creativity and you use it to paint, you're doing watercoloring and you're painting, using creativity in a new way might mean using creativity to resolve an issue with another family member, using creativity to think of a new way to do an old thing that you've been doing, right? So it's finding new ways to use these skills that are tried and true. We're more likely to be successful when we lean into our strengths. And what's really wonderful when I'm working with people with chronic illnesses and chronic pain is they often have such self-doubt. There's such a sense of loss over the loss of their ability to do the things they used to do and a change in how they see themselves. Focusing on strengths just kind of creates that spark again. Oh my gosh, I do have strengths. And it can be a really powerful intervention. So I'll spend the next few minutes just kind of talking about some of the work that we're doing here at the University of Michigan to kind of test the notion of how these fascinating these fascinating interventions are being used. So the first is a study. It's an R01 supported by the National Institute of Nursing Research. And what we're doing, my colleague Dave Williams at the Chronic Pain and Fatigue Research Center and I are asking a critical question. Can cognitive behavioral therapy for pain be made more effective if we add some of these positive activity interventions to it? If we kind of weave them in, will it make the intervention more engaging? Will raising positive emotion be helpful? Will focusing on resilience make CBT even better? And so that is our premise. And so we randomize people to get standard cognitive behavioral therapy, an enriched version, which we call PRISM. It's promoting resilience through innovative self-management. That's just cognitive behavioral therapy with positive activity interventions, or treatment as usual. And we have completed the study, and we are analyzing the data, and you're the first to hear some of the results, the top-line results. But before I do, I just want to tell you a little bit about who the study is for and who's providing the study. So we're conducting this at the Back and Pain Center, and that's an outpatient chronic pain treatment center. And we are working with patients with chronic low back pain who also have fibromyalgia symptoms. So they tend to have more widespread pain and are a little bit more complex and harder for our physicians to care for. The thing that we're doing that's so innovative is that treatment is not being coached by therapists like myself. It's being coached by our medical assistants. And they are so good at this. And so our medical assistants follow a treatment manual, and they call the patients weekly, and they deliver each intervention. So one week they might have pacing your activities, the next week they might have acts of kindness, right, if they're in the PRISM arm. And so the medical assistant follows the script, checks in with them, did they do last week's work? This is the new thing we're going to do, how can we support you? And what we're learning in our top line results is kind of a mixed bag. So we thought that the effect would be immediate, that we would see the primary outcome of changes in pain interference right after they did the intervention. And what we saw is everybody looked the same right after the intervention. Everybody got a little better. Even our treatment as usual got better because they are getting treatment. What we saw, though, was a huge change at 6 months and 1 year. The people in our PRISM intervention, getting the positive activity intervention, are doing so much better at 6 months and 1 year. So that's really exciting. So we'll be writing that up. Wow, sorry guys. All righty. Yep. See, my voice hangs out here. Another study we're conducting is with a colleague. Another colleague in oncology. This is Sung Choi. She specializes in bone marrow transplant, and her interest was always, can we track how well our patients are doing? And so she gave the caregivers an app to help them track their often children patients, and to be able to log and ask questions and stuff. And what she heard from the caregivers is, hey, this is awesome. We love that you're tracking our patients' well-being, but we're not doing great. We as caregivers, this is incredible. Taking care of a bone marrow transplant patient is one of the hardest caregiving activities there is for non-medical caregivers, right? And so she said, hey, can we use some of these positive activity interventions in my setting? And I said, yes. And so what we did is we built an app. And so we have an app that delivers many of these interventions we've just been talking about. Savoring, acts of kindness, pleasant activity scheduling, signature strengths. And what they're able to also do through this app is talk to each other. So the caregivers are all connected through these little chat rooms, and they can talk. And they also get an output of their symptoms, how they're doing overall. So far, I'm so sorry, guys. That might help.
Or there's some
Okay.
one Altoid.
Let me try this. Okay. Okay, let's see if this works. Thank you. And so the caregivers are also able to track their symptoms over time. And this is another study we're conducting here. This is with Mary Janovic and also our colleague Sharia Robinson-Lane. Mary is in the School of Public Health and Sharia is in the School of Nursing. And what we've done is we've taken an intervention that focuses on a walking intervention and added positive activities for it. But this is to target individuals in Detroit, older adults in underprivileged areas, often African American adults. And what we've done is we've woven in pleasant activity scheduling, life highlights, acts of kindness, keeping a gratitude jar, and even savoring. But the thing that they love the most is our module on music is medicine. And it's so powerful, the power of medicine. The power of music. I haven't talked about that much yet because it's not really a positive activity intervention, but it is powerful for people with pain. And we see a lot of music being used in a hospital setting. And what we saw with this little study is that in this pilot, we saw that the intervention group reported that their functional status was much better. 86% of them said that, compared to 25% in the control group, and that 67% of them in the intervention group getting the positive steps intervention said their pain was better, compared to 21%. These were the pilot data for a large RO1 that we have underway now, that we've really expanded this intervention and are bringing it to more individuals in the Detroit community. And this is one more. This is tailoring our positive activity intervention, also kind of weaving it into cognitive behavioral therapy for pain and fatigue in scleroderma, which is an autoimmune disease that has a lot of very, very difficult systemic effects and can be very life disruptive, fatigue being one of the biggest effects. And so for this intervention, we added these positive activity interventions to cognitive behavioral therapy. We used peer coaches, so other people with scleroderma, to help with the to help coach the intervention. And we found that the people who got this Renew program had much less fatigue, much better pain interference, and even greater resilience. So we're very encouraged. There's a lot of work going on. I've only told you about a few studies. There's actually quite a few more. I didn't even tell you about our huge backpack study that we have ongoing. But backpack study is a gigantic multi-site trial looking at who responds best to what treatment. So we give all the patients an active treatment, and we try and identify, personalized medicine-wise, who responds to physical therapy, who responds best to mindfulness-based stress reduction, who responds best to medication, and who responds best to using just an mHealth app, just using a true self-management program. And our hope is that we can do a much better job of matching individuals to treatment, because most of our treatments for chronic pain only work well in about a third of patients. And so identifying who responds to what treatment can greatly enhance our ability to do a better job of care. As I talk about the toolbox, tools for today, first of all, try these positive activity interventions. Please give them a shot. Do them with friends, do them with family, give yourself a little bit of a challenge. Another resource that we have here at the University of Michigan that we have built is the Pain Guide website. This website is developed in-house. It's free for anybody to use. What it offers is a lot of self-care tips. If you click on the pain care and click on self-care, you'll get many of the interventions that we've talked about today in cognitive behavioral therapy, but also you'll get some resilience interventions hosted by me. And that's a lot of fun. We also mentioned that I have a book, and this was my pandemic project. So I watched like the Gilmore Girls beginning and I watched all of Lost twice. And I decided I probably should do something better with my time. And so I thought, oh, I'll write a book, not knowing what a crazy task this was. And so I decided that we do remarkable work here at the University of Michigan and around the world in chronic pain. We know things here that can help so many people, and yet this does not get out. And so I worked with all my colleagues, and we translated all this neuroscience in a most easy, hopefully to understand way. Many patients said, oh my God, I get it. And so we translated neuroscience for our patients very, very gently. I'm a storyteller. I didn't have time to tell a lot of stories here, but that's what I do in my book. I love to tell stories. I have patients telling their stories throughout the book, and they're so compelling and fascinating. In the book, we help patients explore their thoughts, their emotions, and actions, how they all impact their pain, their personal pain. And after they kind of do the first 16 chapters, just understanding everything from trauma and stress and positive emotions and purpose in life and relationships, everything, we have them do a 30-day challenge. So every day the patient wakes up, or the individual reading the book, opens the book, and there's a 2-page spread of a new activity, skill, or practice that they can try. And they just try it. And it can be anything from activity pacing to gratitude, some of the things we talked about here. At the end of 30 days, they go back and say, these are the ones I liked. And then the rest of the book is helping them build a plan that evolves over time, just to be a long-term treatment plan. So the favorite strategies go into their thriving plan, and that's the goal there. I also have a podcast. If you want to hear some of your favorite University of Michigan professors on my pod, please do join us. It's on Spotify and Apple Podcasts, and it's I didn't realize that this was going to be so much fun. What great conversations I have with such interesting people. So I'm having a blast doing this. And I'm very open to people you might recommend would be great for a podcast about pain and health. And then lastly, as we move forward, we as a team really lean into interventions that build strengths in our patients. I think this is an important approach for medicine because we all have strengths, and if we can leverage the strengths within our patients, we're only going to help them heal better, and we're only going to have a better partner. And I think as we move forward, I try to take these to healthcare workers too, because a lot of these interventions can be just as helpful for healthcare workers who are stressed or anxious or burnt out. Using these simple little things like positive piggy bank can really make a difference in a person's life. And then lastly, this is my team. I'm so proud of them. I adore them. They are so young and so bright and ever-changing. We are blessed with having usually 5 to 6 pre-med types, people who are getting ready to go off to go to medical school or get their PhDs, and they usually spend a year or 2 with us, and they do the hard work, but they learn so much about research and patient care. I had to give them a nod. Oh, and we do a lot of volunteer work too because it's good for us. And then lastly, if you want to connect with me, please, you can find me at aftonhassett.com. I note also my funding sources too. I have, I'm blessed with a lot of really wonderful money from the NIH to do these resilience types of studies and personalized medicine studies. And so with that, thank you.
So we have 10 minutes for question and answers.
Question and answer. If you have a question, please come up to the mic or raise your hand if you have a mobility issue or challenges. Do you have a question? I don't.
I've had years and years of chronic pain, but it's only recently that I've gotten into chronic fatigue. And it seems like I have chronic fatigue whether I've slept well the night before or whether I haven't slept at all.
Yeah.
So I'm wondering if it is brain related or it seems more than it's not physiological, because like I said, some days I get good sleep and I still have fatigue.
Yeah. So fatigue is one of our hardest things to address. Thank you for that question. That's why we were so encouraged by the Renew findings. That was the one that we did, the study we're doing with scleroderma patients, and we really focused on fatigue because that is so hard to change. And what we found is many of these types of interventions do indeed respond, but we do think about fatigue also as a brain process, and that if there are things that we can do to kind of change some of the structure and the function of the brain just through our behaviors. Does it help to exercise? If that's the case, do that. Does it help when you, actually, how well are you sleeping? Sometimes we're actually sleeping, but we're not sleeping well, right? That we may not be getting deep restorative sleep. So sometimes that can be going on. We have patients who have chronic have fibromyalgia and chronic pain, and we'll say, oh, I sleep for 10 hours a night, but I wake up in the morning totally not refreshed and fatigued. That's often because there's some disruption in the sleep, so that's something that's important to look at too. Sometimes exercise, just adding a little bit of extra exercise can kind of help. Sometimes our fatigue can come from disuse of our deconditioning from not exercising. So I'm happy to talk to you more about it afterwards too, if you like.
I actually have a question about fatigue also.
Yeah.
I have a sister who has rheumatoid arthritis. She's active. Her pain is under control.
Yeah.
But she also has chronic fatigue.
Yeah.
And actually she's to the point now that when she brings it up, she feels like it gets poo-pooed by her provider. So I actually was going to ask a question about fatigue. That side, I guess as a provider side, working with people that have fatigue, your pain's under control, but she's not being heard where she's to the point that she doesn't even say anything anymore. So I'm going to share with her what you shared, but it just struck me because I'm like, you need to bring it up, but easy for me to say, I don't have it. So anyway, more of an observation. And on your talk on pain, I would never have thought the fatigue part would have been part of it, so I'm encouraged.
Yeah. So these symptoms do clump together. We often see, so my friend Dave Williams also refers to them as the space symptoms. So we often see sleep, pain, affect, so emotion, cognition, and energy. So fatigue, they all kind of travel together. When you get the flu, you probably have all 5 of these symptoms, right? These are kind of our sickness symptoms. She has fatigue that's not being heard. I feel like she needs a new provider. Sometimes we have to vote with our feet because it could be a medication, it could be something that's creating this persistent fatigue, and it would be great to have it looked at. It could even be something that could be resolved through physical therapy, or unless there's somebody that's willing to hear her, nothing's going to get better. So tell her don't stop. Yeah.
You had a lot of information that you gave us, and I thought it was very interesting, but I'm afraid I'm going to forget a lot of it. Where can I go to try to get the high points where I can see all the websites that you talked about and all the references that you mentioned?
Yeah.
How can I go back and find that? What would be an easy way for me to do that?
I'd be glad to share my slides. So if yeah.
It's all being recorded. It'll be on our YouTube channel. You can watch it as many times as
So as he said, it'll be on the YouTube channel. It's recorded. You can have it. But again, you're welcome to my slides because sometimes it's easier to see the references. So if they can't make those available to you, I'll get them to you.
So Roger, her slides will be uploaded to the UMRA website in the presentations.
Great.
Yes. So
Great.
you can go back and
Great.
reference them there.
Great.
So where does motivation come from?
Ooh. It feels very philosophical. I think we need coffee and.
So we
Yeah.
exercise, we feel better.
Yes.
So we get up
Yeah.
and we put on the tennis shoes.
Yeah.
We drive there, and maybe we don't want to go.
Oh my God. I write about this a lot in my book because it is the thing. It's like, we all know we should get up and exercise. Do we know? Right? So, understanding human behavior, we do what we value, right? If it's really important to us, we will do it. We also do what feels doable, right? And so, what I recommend is, number one, if you want to exercise, pick exercise you love, right? If it's something that feels like drudgery, you will come up with every excuse known to mankind not to do it, right? So that's not about motivation. That's just like, ugh, I don't want to do that. Pick something you love to do. Make it easy. Okay, so the thing you love to do is, I love to walk my dog. And so I'm just going to walk my dog an extra 15 minutes, and that's going to be the increase of my exercise, and I feel good about that. Okay, so put the leash by the door, put the shoes by the door. Have all the pieces, make it easy for you. But again, I think it's just doing the stuff you love. Nobody wants to go. Most people don't want to go to the gym, but a lot of people like to dance, or a lot of people like to walk, and so it's doing these things. So we're motivated if we feel like we want to do something. Does that make sense?
Having friends that I work out with.
Yeah, it helps to have someone expecting you to be someplace.
Absolutely. And I love that you said that, because social support, that's the other key. That if you can do this with somebody, that's another piece of it. That somebody kind of holds you accountable and makes it fun. When you're walking with somebody or you're exercising with somebody, the time goes so fast.
Thank you. Jim, were there any questions online from emailed in?
There was only one wanting to know about how they can get to the test.
Oh, okay. So that's the VIA strengths test. If you Google VIA strengths, it should come up. VIA strengths or character strengths, that would come up. And you don't, yeah.
Andy, how are we doing on time?
3 more minutes.
Any more questions?
Oh. I was curious, the app you mentioned, is
Yes.
that something we could use, or is that just restricted to a certain group of people?
So that's kind of where we are with it right now. So we're in the process of kind of rebuilding it. Because it's been successful, we've used it with healthcare workers and students and in many different places. So I think in a future iteration it will become available. It's called Roadmap. And we will eventually, I think, make it widely available. It would be lovely to do a study in older adults, so, you know, yeah. Hello, hello. I'll run it by song.
Any other questions?
Oh, I'll just give a quick, whatever. That's okay, I'm loud. Your book, I just ordered it. Amazon will deliver it tomorrow. So I'm just giving a.
Oh, bless your heart. Thank you. I hope you enjoyed. If you email me, we'll connect and I'll sign it for you.
But I'm serious, I did order it.
Thank you.
Amazon will, deliver.
Amazon is like, I never knew this before, new author person, that, yeah, Amazon is kind of our whole gold. It's how we roll. Right. Well, thank you for the cough drop. I have the worst allergies with everything in bloom here, so thank you so much who brought that to me.